just leave your chairs where you are, and we'll just take comments from the floor. We've got a couple of microphones. We've got Shirley up the back with a microphone, and Stephanie on the other side. So perhaps we'll start with Stephanie. Your group over there. My group now. Yep, all yours. So if you'd just like to perhaps give us your key points from the questions on the board. Do you have a spokesperson, Barry? Sorry.
We only got through the first two questions. There's quite a bit of both of them. I think levels of care, I think there was quite a bit of debate about the two models, you know, where you put the patient at the centre and you build the services around it, versus the kind of structure that we were given with the three kind of specialist components and the primary care generalist component. But I think that there was general agreement that this kind of model could work. I don't think there was any strong feeling around whether it should be 2 or 3, but there was a bit of discussion around how sort of a higher level, for want of a better term, service can work with other services to make sure there's equity of access across the country. One of when we got on the second question, it kind of filled it out a bit, because we've found the whole idea of special care something that we were all committed to anyway. What I mean, it was a bit of a no-brainer, really, but there was quite a bit of debate about what constituted a specialist service. Was it the individuals within and their individual qualifications, or was there some kind of collective component that gave a service the right to call itself a specialist? I think there was thought about how, you know, the level, what are we going? The level 3 services can work with, say, level 2 or level 1 services to provide that kind of virtual specialist cover across the country. Yeah, at the end of the day, this idea of special care was a challenge to hospices to really think about the way they define themselves as specialist services, and this model gave I suppose, a creative framework in which that could be seen as one hospice or specialist service supporting another. But I think overall there was a real recognition that we could talk about all these levels of services to the end of the day, but most palliative care does actually happen in the generalist sector, and that really needs to be the priority. Thank you.
Okay, thank you, Barry. So perhaps now, Steph, shall we come to the front group? Who's our spokesperson? Would that be... Oh, Nikki Twig. Thank you.
Okay, we decided that we couldn't look at all these questions at once, so we picked 3, but only got through 2. And we didn't quite get through complete. So the first question that we looked at was the role of volunteers in specialist care. And after lots of discussion, we came to the conclusion that the question was a little bit shaky in relation to what was meant by that. You know, was that in a clinical environment, or was that in other service delivery? So we all understood that volunteers in palliative care were essential, you know, to help with fundraising and all that sort of stuff, and the domestic chores, which we know that some of them do. But actually, were they involved in any of the bereavement follow-up and things like that? And could we class them as specialist with a little bit of training? So, you know, that was the difficult part. We just didn't know where it went. Okay, so we'll finish that one, because that was too hard. The next one that we looked at was the second one, the difference between specialist care and special care. So we thought that we'd try and define them both. And special care, we decided, was the fluffy bits. And then we felt that we needed to look at specialist palliative care and how we'd like to involve the fluffy bits in specialist palliative care. And actually we had a little bit of a struggle as to whether we were looking at what service specifications told us what specialist palliative care was, or whether or not this was our opportunity to say this is what we think specialist palliative care is. So we've just listed a few things of what we think specialist palliative care is. And so that was ensuring that we have well-educated medical and nursing staff in palliative care roles, ensuring that the right medications are available to provide to our patients, and sometimes that's not so in generalist because there's specialist authorities and things like that that are needed. So also us specialist groups being available to all the tiers that are talked of in the A-frame, and also we wondered if there might be 2 tiers in specialist palliative, in the delivery of specialist palliative care, and that might be associated with an inpatient hospice, or could those services, specialist services, being provided in the hospital with the fluffy bits, or in rest homes. You know, you could almost class some of them as a second tier of specialist care, as long as the provision's involved. Is that all, guys?
Thanks, Karen.
Brenda, I just wanted to say to you, I think you should do some postgrad papers in herding cats for this contract work.
Okay, thank you. Brenda, did you want to say anything at this point around the questions, Nikki's question around the volunteers and specialist palliative care?
No, except that it is hard, and that's why I'm asking them.
Okay, right. Shirley, oh, yep, the group at the back there. Oh, Stephanie, oh, there's a lot of Arahanui people with their little hands in the air today.
It's all Arahanui. Is this on?
Oh, Steph, you have to stand up. That's a new rule. Come on.
No, Nikki didn't. I saw that.
No, it's for the camera. Smile.
Right in front of it. Okay, I've put my glasses on now too. The first question was, we started off the first question. We pretty much spent quite a bit of time on that, really, but we sort of looked at, we definitely need the bottom level, and that's probably the main level. As to how you put the specialist levels up above that, it was quite hard, because it's really what you define as a specialist level of care. And we actually probably could have spent a lot of time debating that as to what is a specialist service, and what's defined as a specialist service, and how do you put more, the different levels within that. But we did sort of think it would probably sit at probably 2 levels within that specialist tier. Okay. Mm-hmm. And that would depend on what services you provide and how much extra services you are able to actually provide. But, so then we went on to the second question, and we've actually got quite an interesting take on this one. And because first, of course, when you look at specialist care, you look at actually having specialist knowledge and being able to empower others and grow others to support them with giving them specialist palliative care, if you look at it that way. But we also had another look at what special care means, and that could actually be owning but not sharing knowledge and keeping it to yourself. So that was just another aspect of what special care is. Is that about how somebody sees himself? So that was quite interesting. Number 3. Well, that was pretty much a no-brainer for us, because you can't have our specialist palliative care without volunteers. It just wouldn't exist, because we don't have the funding capacity, and how you use your volunteers is probably by what your needs are within your region. But they definitely need to be there. So we didn't get any further on that one, because we were running out of time by this time. Again, what do we understand by specialist? I think that really went back to our first question, because we had difficulty to decide, even within specialist palliative care, what would you call a specialist? Because how do you define a specialist in the west coast of New Zealand to a specialist in the north of Auckland? Because actually their roles are very, very important no matter where they are, and they may actually have to have much more specialty than somebody working in a siloed area where they've got everything at their fingertips. Where does allied health fit? Again, if we think very much so within that bigger team. And often with allied health, it's really around their own ambition around what area they want to actually extend in on their specialty. Some physios are very much into respiratory needs, others may be more into other chronic conditions. So it's actually really looking about where they actually want to grow. And when it comes to generous bereavement support, we just felt as a whole that there just needs to be a lot more work around this area. And things are starting to happen in New Zealand, and there is more work going on both locally and nationally around bereavement support.
Okay, thank you, Steph. Yeah, I think your point about the people in the allied teams and the way that allied teams develop in palliative care across New Zealand is that's just the way it has been. That it's been based on what the people in the teams wish to focus on in a way, and that's why we've got so many different iterations of teams. Right, lucky last Biddy.
Looks like I got past the microphone. We were very similar to the first group. We looked at the patient in the centre and thought it needed to be more like the circles with the care coming around it. And then when we went back to the drawings, we reflected on the fact that this is actually looking to define the levels that the providers give, not about the patient in the centre. And our feeling is that there should be 3 levels in total, that yes, primary care is the major and most important, but perhaps in New Zealand, rather than 3 levels of specialists, there could be 2. So a similar thinking as others. We actually only did 2 questions as well. We had lots of discussion. The difference between specialist and special, lots of discussion about this, and we have a sense that perhaps a specialist provider is somebody who has members of the team who are educated and competent at a specialist level. And there's been talk this morning about the fact that there's a good framework for medical specialists, not so for nurses, and perhaps that needs to be defined, and we know there definitely isn't around allied health and needs to be some work done there, but we didn't get on to anything else. Thank you.
Okay.